All right, welcome to The Explainer. Today, we're diving into something that's absolutely critical for you as a psychiatry resident: the epidemiology of bipolar disorder. Look, these aren't just numbers for a test. These are the core facts that are going to shape how you diagnose, how you manage, and ultimately how you help your patients. Okay, so here's how we're going to break it down. We'll kick things off with the big picture, the prevalence and global burden. Then we'll get into onset and presentation, what to look for. We'll talk about comorbidity and the clinical course, then the really tough stuff, risk and mortality. And finally, we'll pull it all together into some key clinical takeaways for you. So let's just start with this one number to set the stage: 40 million. That's the estimate for how many people worldwide were dealing with bipolar disorder back in 2019. Think about that. This isn't some rare textbook diagnosis. No way. This is a major global health issue, and it's a condition you are absolutely going to see time and time again in your clinic. All right, Section 1, Prevalence and Global Burden. So let's really dig into the scope and scale of bipolar disorder. As a resident, you've got to know, just how common is this, really? So the numbers point to a lifetime prevalence somewhere in the ballpark of 1 to 5%. Yeah, I know, that sounds like a big range. But here's the takeaway. Even at the 1% end, that's still a whole lot of people. This means you'll be seeing patients with bipolar disorder everywhere, in the ER, in your outpatient clinic, on the inpatient unit. It's a constant. And what's really fascinating, and frankly really important for us, is that this isn't a static picture. The incidence is actually on the rise. We're talking about a jump of almost 50% in new cases in just under 30 years. Now, what does that tell us? Well, it's probably not just that the burden is growing, but that we're getting better at recognizing it. Which means for you, on the front lines, you can bet you're going to be seeing more and more people coming in for help. Okay, Section 2, the onset and presentation. So we've seen the big picture. Now let's zoom right in on the patient. Because if we're gonna make an early, accurate diagnosis, we have to nail down the who and the when. Who gets this, and when does it show up? So check this out. The classic picture we all learn about, onset in the late teens, that definitely holds up. You can see here the biggest chunk of people, almost 42%, have their first episode around age 17. But, and this is key, don't stop there. Look at the other two groups. You got another peak around 24 and a third one in the early 30s. What this tells you is you can't rule out a new diagnosis of bipolar disorder just because your patient is 30. It has to stay on your radar. And this brings us to a really, really sobering point. 9 years. That's how long a patient might wait for the right diagnosis after their first mood episode. 9 years. So why? What's going on here? Well, the simple answer is that the first episode for more than half of patients looks like depression. It doesn't scream bipolar. So what happens? They get diagnosed with unipolar depression, and that misdiagnosis can have massive negative consequences down the line. And on top of that, you've got to remember that the illness can look different depending on gender. For men, you're more likely to see that classic first episode mania, and you're also going to see higher rates of substance use, especially alcohol and cannabis. For women, it's a different story. They're more likely to present with depression, and they're at higher risk for some of the trickier features like mixed states, rapid cycling, and also comorbidities like eating disorders and PTSD. Knowing these patterns is just a huge part of being a sharp clinician. Okay, Section 3, Comorbidity and Clinical Course. Let's talk about the long journey of this illness. Because here's the thing, bipolar disorder almost never travels alone. It brings friends. And understanding who those friends are, the other psychiatric and medical issues, is absolutely essential. And this chart just says it all, doesn't it? Look at that. Over 60% of patients have at least one other major condition. 60%. So let's be clear. You're not just treating bipolar disorder. You're treating a person who has bipolar disorder plus something else, very often. This isn't just a fun fact. This is a call to action. You have to screen for and manage the whole person, period. Now, this is a heavy one, but it's a concept you absolutely have to grasp: neuroprogression. The idea here is that for some people, this illness gets worse over time. It's not static. Every mood episode, mania or depression, could be, in a sense, toxic to the brain. Think about it. Research shows a nearly 3-fold higher risk for dementia in folks with bipolar disorder, and that risk seems to climb with the number of episodes they have. So our goal in treatment, it's not just about stopping the current fire. It's about fire prevention. It's about protecting the brain for the long haul. All right, section 4, risk, mortality, and prognosis. This is where things get really serious. We have to look at these numbers, as hard as they are, because they show us exactly what's at stake. We're talking about life and death. Just look at that number, 30%. Let that sit for a second. Up to 1 in 3 people with bipolar disorder will attempt suicide. 1 in 3. To put that in context, that is a risk that is 20 to 30 times higher than the general population. This is the single most dangerous outcome of this illness, and it means suicide risk assessment can never ever be just a checkbox. And the tragedy doesn't stop with suicide. That's a huge piece of the mortality puzzle, but it's not the whole thing. People with bipolar disorder are dying earlier from natural causes too. We're talking double the risk of death from heart disease, triple the risk from respiratory problems. This screams at us, right? It tells us we can't just be psychiatrists, we have to be doctors. Integrated care isn't a buzzword, it's a necessity. So you add it all up, the suicide risk, the medical problems, and what do you get? This. 13 years, an average of 13 years of life lost. That is the cost of this illness. And our job, our mission, is to fight for every single one of those years. Our job is to close that gap. So how do we do it? How do we get ahead of this? We start by burning these risk factors into our brains. This is your clinical cheat sheet. You see a young person with depression and they've also got some psychosis or a family history or they're using substances. Your bipolar disorder alarm bells should be ringing loudly. This is our best weapon against that awful 9-year delay in diagnosis. Okay, last section, key clinical considerations. So we've gone through all this data. What now? How do we take all of this epidemiology and make it useful when you've got a patient right there in your office? Let's boil it all down to what you actually need to do. All right, these are the pearls. This is the stuff to take with you. Number 1, screen. Be aggressive about it, especially with young people presenting with depression who have those risk factors we just talked about. 2, think about gender. Remember that men and women can present differently. 3, treat the whole person. Don't forget the substance use, don't forget the medical problems. 4, monitor suicide risk. Always, relentlessly, not just at intake. And, maybe most importantly, educate your patients. Sit down with them and explain neuroprogression. Telling them that preventing the next mood episode is literally about saving their brain, that can be the most powerful tool you have. So I want to leave you with this. This is the challenge for all of us. We have all these clues from the data. We know what to look for, we know the risks, we know the devastating path this illness can take. The real question is, what are we going to do about it? How can we, as the next generation of psychiatrists, use this knowledge to do more than just put out fires? How can we actually change the course of this illness for good?